hear us now?
Yes.
Hello?
But we don't see you now.
You can hear us?
Yeah, we can hear you and see you as well.
Okay, that's very good. Good morning to everybody. Thanks for the GIS for the invitation, and we'd like also to extend our thanks to Edward for giving us such an opportunity to present in the GIS. Dr. Turki will present the case. Go ahead, Dr. Turki.
Good morning, everybody. Our case today is 75 years old, Saudi male who was hypertensive, mostly becoming functionally active, who presented with the progressive shortness of breath 2 to 3, and chest pain over the past 8 months. On clinical exam, he found to have the normal vital signs with all signs of severe aortic stenosis. His lab initially found to be normal and having as well normal ECG. You see here the transthoracic echo, which showed parasternal and short axis on the aortic valve, heavy calcified tricuspid leaflets. And as you can see here, this is the metrics for the aortic valve VTI, mean gradient and velocity as well. And as you see, it's a very high gradient, which is severe aortic stenosis. Here the invasive evaluation with the coronary angio, which found to have mild RTA and normal left system. Here the STS score for this guy, which found to have low to intermediate risk. After that, the multidisciplinary heart team meeting turned and decided for this guy as his clinical status and patient preference and all the low to intermediate risk STS to go for Tavi. Here the cardiac CT, which should be done by Edward, which showed an area of 409, and as you see the annulus perimetry and other metrics. And here on the right side, you can see the tricuspid valve or sinus valve alpha diameters. Here in this table, you can see the measurement metrics from Edward Company, Medtronic, and Prince Sultan Cardiac Centers. And you see the annulus area difference from 409 to 429. So Edwards planned to go for 23 size, and Medtronic and BC to go for 26 size valve. And here you see other metrics for the LVOT area per meter, and we have normal coronary height as well for the femoral artery and common area, and membranous septum is more than 5 mm.
If you keep this slide, Dr. Turki, if you look at the measurement, it's above the line when you think of the annulus size and perimeter between 26 Edward and 23. So I'd like to ask the analyst, what do you think, what valve size should we use, and should we undersize or oversize?
Antoine, would you like to answer their
question? Can you see the measurements? I don't know that you can
see. Maybe the font is so small, so if you can just mention it, so at least we can guide you.
Can you hear us?
Yes, we can hear you. Antoine, I think you can see it on the screen behind us. It's very clear.
I hear my echo only.
Can you hear us?
So I would say that between Edwards and Medtronic...
if you look at the table, you see that there's discrepancy in the sizing between us and between the companies, and that the annulus is borderline between 23 and 26 Edward. So what do you think, what shall we go with? 26 or 23 according to these measurements?
I would go to 26.
I think
I can't hear them.
Hussein, can you hear us?
Can you hear anything?
We are hearing you very well.
Not hear from their side. But shall we proceed in the puncture? Guys, we can't hear you, and it seems you can't hear us.
No, we hear you.
Azam, I think you have to deal with this.
It's fine. So, Antoine, what do you think the size? Their question is about the size.
I would say 26.
And Khalid?
I mean, if you go by their own measurements with a with a
Puncture below the
area
arm.
of 460, that
Go
would
down,
indicate
go
a
down.
size 26.
Okay, I don't know whether you hear us or not,
If
but
you go
anyway, we
with
decided to
other
puncture below
measurements by
the
Edwards with a
bifurcation
annulus
since it's
area
a
of
big artery, and in case we have a
409,
complication,
that would indicate
we
you
can
can
deal
probably
with
get
it.
away with
We're going to use the Manta
23
device.
overflow.
And we are
I
trying
don't
to
think that's,
demonstrate how
I'm not
to
sure
use the Manta
how
device.
accurate that is. I would go with the measurements I made in my
Please.
own center, and based on that 460,
We
so
always
I'll go
use
with the 26.
angioguided puncture, and
Yeah.
sometimes we use ultrasound. It depends on the preference of the operator.
I don't think they are hearing
Seriously,
us.
guys, we can't hear you.
Do you hear us?
Now I can hear you, only now.
You can hear us. Okay. So Hussein and Abdurrahman, according to our esteemed panelists, the consensus here is to go with 26 Sapien 3 valve.
26. Okay, what about, if you show the next slide, Dr. Turki, show us the LDOT classification, if there's significant
Yes, okay.
classification
Can
at
see
the
the
LDOT, if you see below the coronary cusp. Would
Depends
this
on
make
the
any
amount of
change in your plan, or you'll still go with 26?
Depends on the amount of calcification and the STJ. How much is the STJ junction as well, and how high it is?
Yes.
STJ is very high. It's almost 20 millimeters, so the chance of really reaching the STJ is very minimal. You can see the slide now, yeah?
Yes, we can.
Yeah, but STJ is almost 24 millimeter above the annulus, so we have enough height. So you think we should go with 26 millimeter valve?
Yes.
Yes.
Okay. So we'll follow your recommendation. This was the suggestion by Dr. Mogheri. So we'll go with the 26 valve. Okay, now Dr. Mogheri will demonstrate the Manta. I really don't know whether some of you they know it or they know how to use it or not. So we're gonna demonstrate that. Can you zoom in with the camera, please? Sorry.
So as we see the Manta, it's multiple pieces starting from the measurement or the marker. So the marker introducer, usually we take the measurement, the distance from the skin to the anterior puncture of the artery, or the entrance of the artery. So we add with 1 centimeter extra for the safety to be in the lumen, releasing the anchoring inside the lumen. So we'll push the introducer until we see the blood flow back. So now we see the blood flowing back. It's good flow. And we take it out again and get it in to confirm.
So we are trying to measure the depth of the artery.
Now the blood stopped. So we take the measurement now is around 3 centimeters, and we'll add to it 1 centimeter inside the artery. So it's a 3. The measurement is a 3. The distance between the puncture or the vessel entry to the skin is a 3 centimeter.
Okay. All right, we'll go with the Edward sheet. While they are preparing the Manta device. As we said earlier, we punctured a little bit low because of the bifurcation is a little bit high in this patient, just to avoid any complication. And the artery is almost 10 millimeters, the femoral artery below the bifurcation.
So in your practice, you go angiographic guided, huh?
Yeah, we always go angiographic guided. Some of us, they go ultrasound guided. But, for the last 13 years, we are used to the angiographic guided. We assess the size, and we know the anatomy in advance in case we have a complication. We plan our stellar stenting or surgery. Okay, can I have the big tail, please? Big tail is in. Okay, we'll go with the right now.
Strategy in the case of puncturing, do you go angiographic guidance or ultrasound guided?
What we have honestly been doing is angiographic and contralateral injection. So we take a picture from the contralateral groin and use the anatomical landmarks plus road mapping to access. But we have, traditionally that's what we have been doing. We're starting to do Doppler ultrasound more often, but our general practice has been guidance by anatomical landmarks and injections from the contralateral groin.
In fact, we have been using more and more ultrasound, but this is quite recent. And this has been developed for two reasons. First one is that using ultrasound, you decrease the amount of contrast. And second, to avoid failure of manta closure, which is in fact being sure that you are puncturing the artery on the top of the artery and not laterally, which is a synonym of manta failures, then ultrasound is even better than angio.
And also to avoid calcium.
Yes.
Absolutely.
Yes, okay. Give me the ambulance catheter, please. I think it depends on your experience and what do you prefer. Whatever you are comfortable with and experienced with, you will have lower complication. Any new technique always has, a learning curve. And with your learning curve, you will get more complication.
Yes, we agree with you.
A question, with this much of LVAOT calcium, sometimes it may be worth considering the use of a self-expanding valve just to avoid balloon trauma. Was that considered at any point?
26 please.
Dr. Hussain, did you hear Dr. Khalid Shaibi regarding the choice of valve?
I agree with Dr. Khalid. And, I think whenever you have such calcification and borderline annulus, if you decide to go with an balloon expandable valve, it's better to undersize. Or the recommendation is to undersize. And if you go with self-expandable, the recommendation is to oversize. But anyway, since the panelists think we should go with a 26 millimeter valve, we'll go with your recommendation. But we will not, we'll go at, 1 milli lower in the balloon.
Yeah, I don't know if they hear me. The other thing is sometimes when it's borderline, sometimes you may only have a balloon expandable valve, and it's borderline and you're not sure exactly what it is. Actually, still useful to do a balloon valvuloplasty and simultaneously orthography to decide, to make that final decision on whether I go with a 23 or a 26.
You need a computer.
Or the alternative is to reduce 1 or 2 cc initially and see what's the response.
Dr. Khalid, we tried this once before and the balloon did not inflate fully. And it was really a serious situation. It's only 1 cc we reduced the balloon and, it did not inflate. It was suboptimal inflation and we had really to risk the position of the valve. Fortunately, it did not move because we managed to increase the amount of dye afterwards. I think, if you look at the LVOT diameter, it's almost 27. So it should accommodate the 26 valve. 26.
Going back to the procedure, just we would like you to concentrate and just tell us, are you using the other femoral or radial for the pigtail? And what about a temporary pacemaker?
And the pacemaker also. Yeah, we use the femoral. I know probably some they go with the minimalist approach. They use the jugular and the radial, but we are still using the femoral for the.
Most of the cases, the femoral. We do rare cases from radial, and then especially if we have the access in both sides, and immediately you close it with the closure devices. It's making it easier for the operator to concentrate in one side.
Now to deploy the valve, which view you will go with, the coplanar or the cusp overlap?
Okay, so Dr. Adel, which view will you use for implantation?
That's a difficult question to ask a cardiac surgeon. I have no clue.
Okay, no problem. It's good to have a cardiac surgeon while you have the procedure.
It's good to have him here, to be honest.
I wouldn't be the best to answer that question.
Okay, good. Yes, Dr. Ahmed Khashab, I think you have a question.
Yes, thank you so much. If we only look to the CT, it is not only the location of the calcium, but the configuration of the calcium itself. And if you look to the CT, the calcium is triangular with a sharp edge directed outwards. And this is a medium for complication. If you get even a normal sized valve, this is prone to LV aortic annular rupture or LV injury. So here, for this particular case, in terms of the extent and amount and morphology of LV outflow calcification, I strongly recommend the 23 plus 1 cc in the for the valve. Also, one measurement that we didn't have a look here is the height of the membranous septum. So we don't know how high is the membranous septum.
It's 5 millimeters.
So again, this is another indication for a 23 valve, because the short membranous septum with the height of the valve will give the 23 will give more manipulation to where high should we implant the valve.
I agree with you. Our plan is to go with 23 millimeter valve, but since the analysts they think a 26 is more appropriate, we will go with that. We will emphasize with 1 cc, and we go with the cusp overlap rather than the coronal to try to deploy the valve a little bit high away from the calcium and also high in the membranous septum. Once the size of the membranous septum is more than 3 or actually more than 4, the safest valve is Edward valve in these patients, or balloon expandable. Over more than 6, either balloon expandable or self-expandable are safe. So that's why we opt to use a balloon expandable valve. We'll try to deploy it 0 or just below 0 as much as we can. And we will take also your recommendations as we proceed.
Dr. Hussein,
Fadal.
what do you mean, for example, now a little bit high? What do you mean by that? And would you change the technique if you were using a balloon expandable? I mean a self-expandable.
Okay. Will now the shaft. Will it?
Okay, we'll demonstrate as we go. We always use it in relation to the sinuses and the pigtail. Either we keep the duct you see at the middle of the balloon, at the middle of the pigtail circle, or we keep it at the sinus, the base of the sinus, or the curve of the pigtail. If you keep it at the middle, it's going to be almost 0, but you have to manipulate it while inflating. So it depends on how you place your duct at the middle of the balloon in relation to the pigtail and the non-coronary sinus. We're going to demonstrate this while we deploy the valve now. And as you know, the balloon Edward valve shortens from below. So wherever you place it up, it's going to stay there, but it's going to shorten from below. Any question before we cross or any recommendation?
No, I think we'll let you concentrate deploying the valve, and then we'll comment and ask questions.
Sultan, go to the angle, reference angle.
Go to that cusp overlap, just a second. Cusp overlap, please. It's 27, 24. RO code, I think, yeah? Looks good. We'll try both angles and see, and we will see to see which one is more appropriate to use. Okay, let's get Cine, please. Okay.
Cine? This one is good.
What do you think of this?
It's too high. You are too high. You are too high.
No, we're not talking about the position of the valve, about the angio.
Okay.
Okay, let's go to the coplanar, please.
It's good for the calcium.
The valve is in the aorta.
You mean
okay, let's go to the other view first so that you can compare which one we should use.
You managed to scare the panelist and the moderator.
That's good. Okay, let's see me here also.
Hussein.
And you?
Hussein, this is Wael from Dubai. Let's demonstrate to deploy the valve and ascending aorta to see how it looks, then we'll go deep.
Yeah, after this case.
So if you use the co-planar view, I think the ideal is to cross and put your valve down, then you have to remove the parallax in the cusp overlap view to see the actual level where to deploy. So in in cusp overlap view, you have to cross, and then you have to eliminate the parallax to really precisely see your level to deploy, because you're going to deploy high. So cusp overlap is you have to cross and eliminate parallax.
Okay, go to the cusp overlap, please. So which one do you prefer, from both views, which one do you think we should go with?
From a cardiac surgeon's view, I can see here as I am looking from inside the LV. So I can see the annulus is a little bit tilted. For me, for simple thinking, wherever you can get all the cusps in one plane, and you know exactly. Yeah, the coplanar view, but you know, here it's still not, the plane is not very clear.
Dr. Khalid and Ahmed Al-Gindi. So I think this is an Edwards valve. It's a balloon expanding valve. While we can get some information related to the actual depth of implant in the cusp overlap view, I still think that the coplanar view would be the best view to implant. Perhaps you would want to modify it slightly caudal. I'm not sure what angulation, your LAO4, caudal 4, so perhaps going a bit caudal and a bit more RAO might fix that, centralize that right coronary cusp. But I think with balloon expanding valves, the coplanar view will always give you all the information you want, unless there is substantial parallax, and this is where a cusp overlap view can be of help.
I agree with the comments just made. Generally, with the Edwards valve, I use the coplanar view. Your coplanar view needs adjustment. This is what you guys probably assume from the company, but it's not. The coplanar view is actually not coplanar. You need some fine tuning to get a proper coplanar view, and I would use that and then place the middle balloon marker 1 or 2 millimeters above the annular plane. But you need to adjust your coplanar view. It's not truly coplanar.
I think simple rule of thumb for balloon expandable, the best view is coplanar and adjusted accordingly. And for the self-expandable, cusp overlap is a good technique. That's a simple rule of thumb. Yeah, but it depends on the experience of the operator.
Yeah, you can use both to deploy the valve, especially if you are going to deploy the valve high. The best is to go with the cusp overlap. But if you decide to deploy the standard or the classical technique, you go with the coplanar. So we'll go with the coplanar as Dr. Jindi and the others recommended. We already modified the view a little bit, and we're going to cross with the valve now. Okay. What do you think now? The dot is exactly at the base of the sinus. Test, please. Let us take an image.
I'm Hisham Baha. I just want to tell you that I think the valve is not properly mounted, because you can see the dot distally outside of the valve while the other one is done. So I think you have to acquire this information a little bit while positioning your middle marker. So
yeah, we will take it a little bit up. I agree with you. So screen number, sir. Okay, now we'll just pull it up a little bit. Okay, now it's in relation to the big tail. It's almost in the middle of the circle of the big tail. Are you happy?
Is your pacemaker?
Is everybody happy? We can proceed?
If you aim to adjust a little bit higher, the adjustment of the valve will not be on the central knob. Would be I'll target the little bit loosened marker band just above the lower edge of the valve, and that is how I would place the valve with this band on the annulus. So this makes the adjustment of a little bit higher position much more easier.
Do you mind if we take a picture just as a final confirmation before you deploy it? So
let's take a second.
Yeah. Patient is creatinine is normal, so we're fine.
Yeah, he has normal kidney function.
Can we have the Casper for lab again?
This is a very good view.
أعطينا Casper for lab.
Since he's stable, we can still change the views and discuss. Okay? Go more caudal until, okay, that's good. Test now. You see, I think we are a little bit high even. I think this is a good position if we go with it.
Okay.
What do you think, Antoine? Should he deploy now or?
Yes, I think it's time to deploy.
Khaled?
Okay, go to that coplanar view again.
I'd like to see the coplanar view one more time. Like I said, it wasn't coplanar, but I'll use it. And just aim for about 2 millimeters above the annular plane on the coplanar.
I believe this is good. Okay, basically
take a picture here with pacing.
Wael, do you want to comment?
So usually we place the big tail in the right coronary cusp. For the people who want to use the cusp overlap, they have to put it in the non-coronary cusp because it's going to be deceiving for them.
Of pacing?
Can we see the hemodynamic if it's possible?
Yes. Can you see it now? Guys, show them the screens, please. He's coming back.
Push the wire.
So this is 26 minus 1 cc?
This is 26 minus 1 cc, exactly. Okay, take it back, please.
شير البارلكس شوي more caudal more اليوم خلاص okay زين. This is good.
Okay, you can see that the diastolic pressure is almost 65. So most likely it's well deployed. There is no aortic regurg.
Ready for sending?
We will take a series now. It's good. Okay. The position is excellent.
Very nice.
The coronaries are patent, and we have good space in the sinuses with good flow, no stagnation.
Do you check the gradient by hemodynamics at the end of the procedure, or you just check by echo and aortogram?
Actually, we always check by echo and aortogram. You know, we never cross again.
Okay. Did the person again?
In this case,
we don't like
It looks perfect.
You know, this is the beauty of balloon expandable valve. Most of the time you don't get any regurg. It's more anatomical to the annulus with less contact with the aorta. And we know that the coronary access in the future is much easier with the self-expandable valve. This does not really put down the other valves, but in such a fit patient, probably self-expandable is better. Sorry, balloon expandable.
I mean, the aortogram doesn't show any PVL, and coronaries are filling, so that's a good result. So I think the size was perfect.
The position was perfect. The rhythm is perfect.
Yep. And we see neurocomplex ECG. The hemodynamics are excellent.
You know, one of the things with the self-expandable, we always have that small whiff of paravalvular leak that they say that it will go away, and it does in most of the cases. It does go away. But here, there is no paravalvular leak at all. MashaAllah, tabarakallah. Congratulations, Dr. Hussein and Dr. Abdurrahman.
We rarely see paravalvular leak with with balloon expandable valve. It's as you said, it's more common. It's at least 30% with self-expandable in our patient. But with balloon expandable, it's really rare. That's extra step. Okay, now we will demonstrate how to close the axis with the Manta device. Can we have the zoom in, please, to the groin? And if we are obstructing the view, just tell us to move away.
I promise you, we'll give you enough time to ask questions because, mashallah, tabarakallah, the operators are ahead of time, mashallah. So we'll have time for discussion, inshallah.
Okay. So we should have made it a little bit longer. But anyway, you guided us to go fast.
I think just a lot of the audience, they don't have much experience on the Manta closure, so we'll give you time to explain it step by step if you don't mind.
You know, if you noticed Mugheri at the beginning, before we start the case, he measured the depth of the femoral artery, which is by CT around 34 millimeters, and by also the Manta measurement device, it's around 30 millimeters. So this gives you the impression where to deploy your device, inside and outside the artery. It's like a sandwich. You sandwich the artery from inside and outside. Can you see the device? Aziz, I think you are obstructing the way if you come this way. Can you see it now? Okay, this is the sheath now. Yes. Okay, this is the sheath. Let me take the pressure and you explain to them, please. Please. Okay.
So the introducer and the sheath will sheath it again. This is 18 French sheath.
Yes, put your hand down so that you can see.
So as usual with the sheath introducer, but this time we'll go with the back to our initial measurement. We measured it at a 3. Now we'll deploy the sheath at 5 centimeters.
It's like a big angioceal, by the way.
So it's like a big angioceal, yes. Okay, so we'll take the
can you see?
The introducer out at 4 centimeter depth.
Yes.
Because our measurement is 3 centimeter. And now we'll introduce the plug.
This is the plug for the sandwich device.
Yeah, it's okay. Should go completely out.
Go.
All right. Okay. So we push it in. We are at 4 centimeter depth. Now we'll go until we hear the click.
It's the same click, but it's louder like the one in angioceal. And now you have step 1 and 2 and 3.
So we are inside now. And now we release the anchor inside.
We can remove them down, from down so that they can see. No,
so take the wire out. We have 2 options. Either put the wire in. No, it's not going to help because you cannot go inside with the after we deploy it. Take the wire out. Okay, take the wire out. Okay. So now we pull everything out with the pressure on the skin to stabilize. Now we see the initial stretch of the anchor inside. We push the anchoring device to anchor it, and we stabilize it inside. Okay. With maintaining the pressure or
I think you are in the artery.
No, it's not in that.
Pull back.
Yeah, it's up.
Yeah, it is.
Okay, so we'll confirm 40 minutes. We'll leave it for 2 minutes at this level.
Of course, we know from studies that complications vascular with Manta device is much higher than the proglide.
Yes.
Probably because of the learning curve.
Still So give us the lima, please, from the other side.
He's still bleeding, so the manta did not hold well. Okay. Aziz, help me, please. Over the wire. Back. In case we need, we'll just stint it since we are below the. Okay. Pull back down. Connect. Okay, that's fine. Just Brian. Okay, show me the groin, please. Okay,
yes, please.
Ready?
Yes.
Inject.
There is some. No, it's not in a good position. البكتيريا كانوا show me the lima, please. Up.
Show me up, please.
Okay.
Yes. Okay, keep it stable.
How many cc?
While they're dealing with this question, anybody do classification or use the standard or the classification for LVOT classification when is reviewing the CT for the procedure?
Sometimes you need to breathe for a few minutes before the hemostasis is.
Okay, since we are talking about closure and what's your practice, Antoine, in Paris? Do you use proglides, 2 proglides, 1 proglide, angioceal, or manta, or?
We have been very fond of Prostar for a long time, which is a difficult learning curve, but after having undergone all the complications with the Prostar, then we heard that the Prostar would disappear, and then we turned to manta, in fact. Some people use proglide, but manta, as I said, sometimes may be a little tricky, like in this case. And as I said before, the trick is really to be on the top,
being anterior puncture,
and yes, and avoid any calcification like with the other systems. But manta is really 90% what's used. 95%.
I think this highlights the talk I just gave earlier today. I mean, ultrasound is certainly a very good way to do it. And as I showed in a couple of studies there, it has been shown to be maybe superior in some aspects to an angiographically guided strategy. But I'm not sure. Was an angiograph? Did they do contralateral injections and then they access? If you had done that, you'd have recognized that SFA. You should have been higher.
Is achieved now. Take your hand away, please.
I think you like cut down as a surgeon.
I do, and I think there's a lot of
okay, anyway, we actually demonstrated there is minimal oozing.
If you had a cut down now,
with time.
The other thing is the cut down. Not every cut down is like the other. Like you see a surgeon, they do like an extensive cut down, and they really dig deep for the femoral artery. No, you do a very targeted cut down, like the cut downs we do for our minimally invasive cases is not more than 2.5 to 3 centimeters. So it is like exactly like even less than that. So we go directly ultrasound guided towards the femoral artery. You know exactly where you are opening the skin. You open the skin on that, and it needs a little bit more experience, but not every cut down is like the other.
So minimally invasive cut down.
Minimally invasive cut down, and here you can see. I saw this picture with almost all the closure devices. You have to lose at least like 50 cc's of blood, and in cut down you lose practically like nothing, no blood at all.
Okay.
I think the majority here are interventional cardiologists. So,
well, I am the only surgeon I was invited.
No, I think there is another surgeon in the room as well. Dr. Ahmed, sorry, I've been waiting for some time.
No, absolutely. Just would like to grab your attention that the technique used here for the manta is not the technique that we recommend that to go in first, go out with the blood in place to keep the liver roll and then make the pull back. Dr. Mogheri, he used a different technique that he introduced the liver and the plug after he withdrew, and this is a little bit different than the recommended technique. The other thing that I heard one click, I didn't hear the two click, maybe because of the live transmission, but you have to make sure that two clicks are here before you start the otherwise the blood will not be in the correct position to grab it backwards. Thank you so much.
Nice tips. Dr. Tfadal.
Rahman Al-Qahtani, interventional cardiologist in Medical City. So a couple of things, just comment. First of all, we just had a recent trial that's just been published, head-to-head Manta versus Proglide. So blood-based versus closure suture device. And the blood-based was about almost doubled vascular complication, 3.6 versus like 1.7. Yet we're still leaning toward using something that does show that doesn't work. So I just find it hard why we're still pushing for large bore closure device like Manta, where you have a very good system that works, like a Proglide. The second thing is you don't have to go with 2 or 3 Proglide. You can do always with one. All of our cases we do with one Proglide, and we don't have any issues. We might have to apply a little bit of pressures, and we get away with it. In terms of cut down, yes, cut down you do it when there is vascular complications because the risk of infection is higher with those patients. So I think in cases where you know there is going to be a problem, cut down always the best. But we don't have to go for it unless there is a need for it. So that's what's my comment. Thank you.
I think I agree with you in many of the things you said, but it's always technique. You can use a suture-based system, but your technique is not very good. You get into problems. Using a plug says you cut corners, you don't follow the exact protocol, you run into problems. So I think whichever system you're using, you need to use it appropriately with following all the rules, assess your site, your puncture site beginning properly so you're in the right spot. You're an anterior puncture, you're above the bifurcation, and all these things from the beginning. I think if you do it correctly, you can't make a blanket statement, this is better than this. I think it all depends on technique as well.
All these devices, in terms of, you talk about the valve or you talk about closure devices, is always a learning curve, and you have to be familiar with them and know the right technique how to do them. That's very important. So, Fadal, Doctor.
Hi, everyone. Yasser Sadiq from Egypt. Actually, we didn't have Manta in Egypt till now. We have a good experience with Proglide. But my comment here is that when we do vascular puncture, femoral puncture, we have to look at the site of bifurcation because still we have a failure rate for Proglide or for Manta because the blob of calcium may be there, maybe in the wall of the femoral artery. And when you go for hemostasis post, you have some cases of failure, and you have to put a graft step. Here, in the bifurcation, if we intending to put a graft stent, we will close the profunda femoral. So, in the Manta, should be above, or there is another trick for Manta? What is your experience for that? So So this is a must.
All closure device. It should be above the bifurcation.
This is a must because the graft stent will close this. So in this case, the puncture lower than the bifurcation. So this is a problem for hemostasis with graft stent.
It is a problem that the puncture was too low below the bifurcation, and this is very important even in the choice of the femoral artery. When the bifurcation is very high, then you have to puncture the other side.
Okay, thank you.
But it is not related to MANTA or the closure device are concerned.
Thank you.
Fadal, Doctor.
I'm Walid Kadra. I'm an interventional cardiologist in the UAE. I know everybody is concentrating on the closure device. I kept my eye on the ECG, and I noted that the patient is alternating between just running around 100 and then dropping to 48 or something. So I don't know whether they removed the pacing wire or not yet. But with this situation, there is some data that if you take the pacing wire from the ventricle and put it in the atrium and pace around 120 and see if he continues to conduct 1-to-1, that's mean there is good conduction system and no injury has been done. And so I don't know whether they removed the pacing wire or not. They haven't. I don't see it.
We will check with them and once they control the situation. Any comments?
One final comment is the closure.
Ahmed Khashaba for the fourth time. Tfadal.
Last comment. The choice closure study that was mentioned, comparison between the MANTA and the ProGlide, ultrasound usage was only 25%. And this was a major drawback of the study. MANTA, to be successful, should be 100% ultrasound guided to choose the top of the aortic, of the femoral artery at 12 o'clock exactly. Then you have no complication, hopefully, so ever. But the choice closure is not the study that we depend on to compare because of the low usage of ultrasound.
Ahmed, we enjoy your comments, or feel free anytime.
Fahad. Here, Fahad.
Great. This is Ayman Saleh. Great comments from my colleague about the use of ultrasound. I think one of the main steps here is that to identify calcification and the exact soft spot where you enter. And that may have contributed to the complication that we're seeing. But also the MANTA device, the new devices, we also have to always try and push the envelope and use new technologies and not get comfortable with our prior knowledge about perclose or whatever. So I think using new devices that are safe and getting proficient with it is the way to go.
Agree.
Thank you. I think I will agree with all the comments so far. We started with the start close. We had a long time with the start close. Then we introduced ProGlide, either 2 or 1 ProGlide. Sometimes you do 1 ProGlide and you add Angioseal 8 French, and it's very successful. There is another one which is ProStyle, which is a new device from the same company, and it's good for calcified lesion. Like we had some complication with the ProGlide that if it is in a calcium, the thread will cut in you. We use few of them, but it's not available all the time. Now we introduce, or the company, they brought us the MANTA 14 and 18. We are using the MANTA for like the umbilical cases. It's good. We introduced the MANTA also for Tavi. I think it's a learning curve, and maybe in 6 months or 1 year, most of the people, they will be familiar with it. It's a new technology. I think we will not close the door. We will use it carefully and go step by step as the company instructs us.
I agree with you. I mean, it's a learning curve at the end of the day with any devices that we use. The tricks in using these things is ultrasound guided, puncture anteriorly, and avoid calcium as much as possible.
The only thing I will add, I think, our equipment and it should be ready for such thing happen. Like suddenly, you have to be ready with all the equipment, like for complication.
And the thing here is what we see is a real life case where every time we get happy, we deploy the valve, no PVL, we're so excited, and most of the time is the peripheral which is delay us, and I think there is more room to improve in that matter. Dr. Wael.
Hussein, did you reverse the heparin? You give protamine?
Yeah, we did. Exactly. The ACT is 100 now. So we reversed the heparin. Sometimes whenever you use a new device, you expect some failure and complications. You can't always succeed. So probably this is one of the cases we have failed manta. There is some still bleeding. We will balloon it for a few minutes and see. If not, then probably either we call the vascular surgeon or we will deploy a stent. I know that stent is not recommended at junctions or at joints, but we can at least save the situation. We opted to puncture below or a little bit low, as we discussed earlier, because the bifurcation is high in both sides, by the way. So if we punctured up and the manta failed, it will be really serious, and most of the bleeding will go to the retroperitoneum. So that's why we opted, since the artery is really huge below the bifurcation, is to go lower, which will be safer, at least in case we need to open or in case we have a complication, which we already have.
And the superficial is 8 mm.
Yeah. So we will balloon now for a few minutes.
Yeah, no, I was going to suggest long balloon tamponade and reassess, and after that, probably a small open repair is probably better than just a covered stent SFA.
I agree.
Doctor.
I think it's about time to, this is the first time actually I attend interventional cardiology meeting, and thanks to Fawaz for this invitation. It's very enlightening to hear the discussion. And I would like to just highlight the importance of really, we need to change. If you see a problem, it's a repeated problem. It's not to do with Gulf. It's not to do with US. It's not to do with Europe. Vascular complication is a universal complication. Tools being used over the years, different techniques by very skillful people. Data confirm vascular complication is real and it's staying. Shall we change? I'm really interested in the comment of Dr. Khalid earlier. We are not going to go backward. Going forward is the way to do it. Doing it right. This procedure took to implant the valve less than 15 minutes. We're spending 1 hour to deal with a problem which could be avoidable by just selecting, individualizing the care by small incision. Selecting, not every patient needs that, but certain patients will benefit. So we really need to go for zero complication, and this is my view.
We have another surgeon in the room.
Happy to hear that. Yeah, I was starting to feel a little claustrophobic.
How many just little bit. Is it? Okay, yeah. Cambona.
Tavi is a surgical Tavi implanter.
That's fine.
Person cut down in his case. Very interesting. He feel happy with it. He feel like he do a better job. So, and his outcome, I'm sure, is and
if you allow me, maybe.
I'd like to ask Dr. Lafonte, sitting next to me, how many TAVRs in Europe generally are done with surgical cut-downs?
Now or 10 years ago?
Tell us both scenarios.
We started in Pompidou in 2008 with 100% cut down, okay? And then we went in the 2-3 years after with ProStar, and there was a hybrid cut down. So we opened quite clearly in order to have those 25 French valves able to go within. And now there is the only cut down that we have is a carotid or axillary cut down. So I was wrong. So the answer precise in Europe, I would say, is around 10% cut down, but it is not for transfemoral.
Very good. So, Hussein and Abdurrahman, I see that you are inflating a balloon. Can you tell us the size of the balloon, if you don't mind?
Bleeding out. It's 8 by 40 millimeters balloon, according to the size of the superficial femoral and also the femoral artery. So we will leave it for 10 minutes and then reassess again.
Okay.
Dr. Hussein, Dr. Abdurrahman, thank you very much. It was excellent valve deployment. But I think in order just to control the situation, that's why you need to proceed with the cover stent, then you consult the vascular surgeon later.
Yeah, we will. I think if there's still bleeding, we will just save the situation, as you said. We'll just stent it as a bailout. It's easier, simple, and we have, as you know, we have experience with this, with our vascular complications because of the high volume. Whatever you do, by the way, whether you do cut down or not, there's always a complication with every procedure that you have to have. If you do 100 procedures, you will have 1 or 2 complications. If you do 1,000 cath, you will have 1 or 2 left main dissections or whatever, right coronary dissection. This is fact. Nobody can overcome this. This is part of the procedure. Fortunately, the bleeding is controlled now. So we will reassess again. If there's still bleeding, we will just put a stent.
Okay, Dr. Hussein, we'll take some questions from the audience meanwhile until the balloon tamponade is over.
Excellent case, Dr. Hussein and Dr. Rahman, for this good demonstration for peripheral vascular complication. After you gave brutamine, now the ST is 100, and now it's a long balloon inflation. So did you give heparin before this, or you will keep the ST like that to avoid more complication? What do you think?
Always bleeding is more serious than thrombosis. So we'll try to control the bleeding. If it works, fine, but we will not give heparin anymore. I don't know about the audience or the panelists. Once we have a bleeding complication, we don't give heparin.
Yeah, I agree. You do not give any heparin, and you can do a very, very long balloon tamponade here. This is not the heart, so you can be there for 15 minutes, 30 minutes.
It's the femoral can tolerate.
Yeah, the peripheral vasculature can tolerate long balloons and long tamponades, and I would do it as long as it takes. You can take your lead off, come back, and take a relook. There is no hurry here. Even if we go offline, it's fine.
Mr. President.
Thank you very much, Dr. Hussein and Dr. Abdurrahman. A great job. Thank you very much for a great live transmission. And I think we learn more from vascular access than the implanting of the Tavi. My comment really is whatever we do and improve in implanting Tavi, at the end it should be case by case. And whatever the patient need, it should be done for it. So there is no, and we shouldn't label anything as old practice and new practice. So cut down is never be an old, and percutaneous never be a new. If the patient need a general anesthesia, should be applied to it. If the patient need a TE, should be done. And if the patient need a cut down, should be done for that. And the aim should be a best practice and less complication. So every case should be discussed. If the patient have high bifurcation and the access is not perfect, I think planning of a cut down. And nowadays we do a minimal invasive femoral access, which is almost 1 centimeter of a cut down, and that will take it to the best practice.
It's a customized procedure, so and depends on the pre-planning, which is very important. So I agree with you, Dr. Fawaz.
Dr. Hussein, Dr. Abdurrahman, again, it's Ahmed Al-Gindi. Excellent demonstration. I mean, very quick procedure. You just had to buy us some more time for comments and discussions. But the patient is stable as we see. I just want to comment على كلمة Dr. Fawaz. Now, absolutely, yes, individualizing and tailoring therapy is important. But we also understand with how coronary angiography evolved. If we had been doing coronary angiography and PCI via brachial cut down until now and saying this is the absolute safe way of doing it, this is a very superficial artery. It's not in the groin. Risk of infection is 0. But the introduction of a Seldinger technique and Henry Judkins essentially revolutionized PCI. And we're moving, so we do our axillary access percutaneously. We do a lot of ECMOs where I come from. But I do agree that there are some patients where a cut down is tailored and planned ahead would save us a lot of trouble. Having said that, the patient is stable. We actually have four or three different solutions now, and we're seeing moving from one step to the other in a customized fashion. But I want to ask you, do you think that this patient would have been a surgical cut down from the beginning? The only femoral patients that I do a cut down now, if the femoral artery is 10 centimeters deep, and there's no way we know the percutaneous closure device failure rate is quite high in this particular cohort, those are cut downs for me. But would you have opted for a cut down on this occasion?
No, definitely I'm not talking about this patient, and I'm sure they will manage it appropriately, percutaneous, either by balloon tamponade or river cost at the end. So if it's my case, I will go ahead with the percutaneous exactly. But I'm talking about a general statement, because I felt that some people think that cut down is an old strategy. I think it's still there if needed. And to answer your question, this patient can be done percutaneously appropriately.
I mean, with the development in Tavi, the devices, the sheet size, and the closure devices, I think the major thing is percutaneous. Only few selected cases can be done by cut down, as Dr. Junaidi mentioned. If you have really a very obese gentleman and it's too deep, then yes, I will agree. This highlights something else also. I mean, vascular complication is there, and we will have it in our daily practice. The most important is to have the right tools in your cath lab. So you have to have the peripheral tools ready in your cath lab, from balloons, stents, different wires, everything. And also, I mean, to have in your heart team, just to let your vascular surgeons aware that on that day we have a Tavi case. So in case, for extreme cases, you will need them for bailout, they should be there to help you instead of you regret it. I think we have very controlled situation. Patient is hemodynamic. From the beginning, I will just show raise of hand. How many of you will go with cut down from the beginning? Anyone? I don't see even the two surgeons.
I will put my hand if the surgeons, just to support.
Okay, yes, Antoine.
Honestly, there was no indication for cut down. To my experience of failures, of complications, the age is a very good factor or predictor of failure of any closure systems. Because in fact, after 90-year-old, the CT is totally underestimating the real situation of the vessel. And I think the surgeon at this point, they become absolutely mandatory, because I don't see any standard system be able to close an artery which looks in fact like a piece of wood, a mixture of calcified and fibrotic and almost dead tissue. So you open it, but you will not be able to close it. And so the question is not the depth, the question is the status of the artery.
Just have a comment about this. First of all, defining what is progressive and what is going backward. I think this is very important, and I do not believe that if you tailor your cases and use a cut down in some cases where you have a deep artery, or you have more calcifications than usual, or you have a very high bifurcation, that is not going backwards, that is progressive. The second thing is discussing these cases in a proper heart team meeting with a cardiac surgeon and a vascular surgeon, but a lot of cardiac surgeons, we do vascular as well. So we could deal with complications, and we did a lot of these complications. And I personally fixed a lot of femoral arteries and did some bypasses in the femorals. The third thing is even having the surgeon in the room with the implantation team. I would think that that is something that, every team is not complete without the surgical part with them, giving them some perspectives, helping in certain cases, even like being part of the team and being part of the implantation team. So this is. I think a lot of, I don't know if in Europe is it mandatory to have a surgeon as part of the Tavi team or not, but I know in a lot of centers in the States, it is mandatory.
I cannot agree more. It's important to have the heart team, and I go back to the pre-planning and also being standby for it. I'll go back to the case and we check with Hussein and Abdurrahman. So what happened after the balloon inflation? If you can just give us an update.
After we still have some oozing, so we're going to go ahead and stent this with a self-expandable covered stent.
Okay, good plan. Travel. Yes, doctor.
And we're gonna oversize a little bit. The artery size is 8, so we're gonna go with the 9 by 40 millimeter stent.
9 by 40. Doctor, please.
It's Dr. Fayaz from the National Guard Hospital in Riyadh. So first of all, wholeheartedly congratulate Abdurrahman for doing such a good case. Two things in here. First of all, the bifurcation, we know that any puncture, even like 6-7 French, below the bifurcation will lead to more complications, and from all the data which we know. So that's, I think, important to consider. Like we have a criteria for our own hospital to where we should go cut down and where we should do percutaneous. As you know, we do a little bit more cut down than the usual centers in the region, probably. And we have one of the criteria is high bifurcation. So any high bifurcation, we prefer to do cut downs on that. Although this may be an exception because here we have a bigger artery distal to the. Second comment and question is, what's actually the mechanism here what's going on in here? And I think that's important to take into consideration. So there are two factors. The problem with the Menta is we had recently, we deployed a Menta and it completely closed the artery completely. We had complete occlusion after Menta. And what we did was we went contralaterally and we took a bigger balloon than the size of the artery and inflated for about 10 minutes and everything went okay. I think the issue here is that the plug is acting like a door here. So there's two issues. One is obstruction, partial obstruction, and also not sealing and that's what is causing the problem. So I think to deal with that, it'll be a bigger balloon because I saw the balloon size was a bit smaller, which they used. I think maybe a bit 6 millimeter. Probably if they used a bigger balloon, that might have actually helped them better. And two is obviously to go for it's not really a bad idea to go for a covered stent in here and save the day.
And think that's what they are doing now. So we'll go back to Hussein Rahman. So
yeah, we are deploying our covered stent as you see. Okay, let's take an angio now. And we'll bear the balloon again. You know, as Dr. Fawaz said, every patient is different, and we always individualize the treatment of fibrillation according to his clinical features and also according to the anatomy and the device characteristics. There's no rule whether you puncture below or above the bifurcation, but in this patient we opted to do that because the bifurcation is high. And if he had a complication, we will have, higher much higher risk of mortality and morbidity in this patient than if we puncture below. We know that low puncture is always associated with high complication, but sometimes you have to go for it just to avoid more complication in case you have a complication. Okay, now it's well sealed as you see. Can you see it? Can you see it, guys?
Very clearly, yes. Very nice result. Excellent
result.
Yeah. I would post-dilate that stent with a nominal
exactly.
balloon.
We will do that now. Sure. Okay, give us a...
Good, excellent result.
That's a 9 by 30 balloon. It's 9. So we'll use the same balloon.
Dr. Fahad. Just for the history, Dr. Hussein Al-Amri is the first Tavi implanter was maybe in the Middle East. He did it in April 2009. And with Dr. Saad Al-Qasab. And since that time, he had really huge experience. And Dr. Al-Mughayri later, he joined him and they really formed very competent and strong team. And they know how to deal with all challenges and complications like this.
This does not mean that we have a lot of complications, Abdullah.
So I think they don't want to make it boring for us, straightforward case. So they want to make it very interesting to us and how to deal with vascular complication, which is also a teaching point that we all learn from it.
Hussein, I will come and do fellowship with you with complication, just to teach me complication.
You forgot that it was a transapical valve, transapical approach, the first TAVI. صح Abu Talal? It was a transapical, the first TAVI.
Yeah, we started with transapical, yes.
So the surgeons.
And we remember Adil when you also were with us. Really, cut downs is always nice. The problem. We never had a vascular complication when we used to have cut down, but the length of stay and the infection rate was a little bit high. We used to keep the patients for 10 days to 2 weeks until they heal. Some of them, they get infection, and then even if they stay longer. Cut down, yes, is a solution, but I think only in certain patients at this point. When you do 100 patients and you get 1 or 2 where you need to go for surgery or stenting, this is good. Rather than doing 100 as a cut down with higher complication and higher rate of infection.
I totally agree with you, Abu Talal, on that. طبعا the infections used to come because you used to do the TAVIs in the cath lab. In the cath lab, you don't have the laminar flow and the control. But now you have your state-of-the-art hybrid, which is inside the OR, very controlled environment. I doubt that you would have a high, like any infections, in fact, with a cut down in your new setting. But I totally agree that tailoring every case is the way to go.
I have only 30 seconds. So if
it's only going to be 30 seconds. So I think I learned from my own experiences and my own failures and my own complications too. 2 things I will just want to share with the audience. Now, this was a perf which was slow. We have time to deal with it. So I use the acronym in my lab for either coronary I perforate a lot of coronaries during CTOs. So I use the acronym. When I see a perforation anywhere, I remind everybody it's a BAD, balloon and deliver. So you balloon it, and then you have time to think about what you're going to do. This was a perforation that you can control. Sometimes you cannot control. So think about balloon and deliver. The second thing which we have adopted in our lab, an acronym which is adopted from a colleague of mine from the States. We use PETAL, P-E-T-A-L-S. So if we go to this case, was this predictable? P stands for predictability. Then number 2E, what was the event that happened that led to this? For example, is this a failure of the closure device? P-E-T, what did you treat with? We treated this with the balloon tamponade, and then finally we had to put a stent graft. A, what advice do you give? Probably use all the modalities that you have to avoid this complication. L, life lesson learned. And I'll add the S, did you have the support of your colleagues? And they, of course, he did have it. And I thank you for that.
Okay, just before we conclude, I would like to congratulate the operator. They're very experienced operators, Dr. Hussein, Dr. Abdurrahman, and the whole team for an excellent demonstration of a Tavi case with vascular complication and how to manage the complication. So, would you like to say any final word, Dr. Hussein and Abdurrahman?
Well, thank you for the nice comments, and thank you for the nice moderation, and I'd like to thank Dr. Fawaz for his invitation. Thank you all. Have a good day.
Thank you.
I might just open a question for, from imaging point of view, and thank you. I mean, this is a great case. It is the problem with the discrepancies between measurement of the center and the company. Like, I always do my measurement, but I don't know who the intervention will take, my measurement or the company measurement. After 12 years of doing TAVI now, shall we still go with the company measurements, or we depend? Okay. This is my question. Yeah, and should you send the CDs to the company? And the other thing, keep in mind that the report which is in the hospital is the hospital report. So from accountability point of view, you are accountable for the report which is in the hospital. So why should we just go with the company measurement now? Shall we just stop that and go with the hospital measurement after many years of?
Sorry, a comment and a question. So these are around the room. There are very, very experienced operators with large volume programs. Why are you even sending the CDs to the company for measurements? I'm just wondering, because I would understand that in a program that is just about to start or very nascent or early on. But what we actually advise people is to the operator themselves to make the measurement, because it's one thing to look at a report. Imagine if you're going for PCI after reading a report. So we advise operators, and nowadays our fellows, they have a 3-month mandatory CT and MRI training because they will be just using it in all the complex and structural interventions. So in all honesty, in such large volume centers, I don't see a reason why we should be sending the studies to the companies.
Actually,
and the operators should be doing it themselves.
This is my question. I mean, and you can see at the beginning of the case, there was discrepancy, and it completely changed the management plan. I mean, from what was decided 23 to what was decided here, 26.
Thank you very much, guys, for this debate. I think it depends on the experience of centers. If the center is still at the beginning, then they can go back to the company and depend on their measurements. But I think you have to have, if you label yourself as a TAVI center, you have to depend on your own measurements. Okay? So I would like to thank Prince Sultan Cardiac Center, the operators, Abdurrahman and Dr. Al-Amri Hussein, for an excellent demonstration of a TAVI case. Also, I would like to thank my colleagues here, Dr. Antoine Lavant, Khalid Shebi, and Dr. Adel, for their contribution. And I would like to thank all the audience and for your excellent contribution. And I like the integration part of this session. Thank you all. Thank you.